Welcome to everybody for my lecture series. And today I am discussing the comparable inotrope and vasopressor needs found for LVEF, left ventricular failure, CABG patients. A new study has found that perioperative inotrope and vasopressor requirements are comparable between patients with low, that is less than 16 to 35%, and very low, that is 15% left ventricular ejection fraction, undergoing isolated coronary artery bypass graft surgery, that is CABG. The investigators concluded that these two groups of patients can therefore be treated comparatively as a safety net hospital. We can see a safety net hospital, we see an underrepresented group of patients who was relatively sick, particularly among those who typically present for cardiac surgery. This is from the Medical College of Georgia, Augusta, US. Those patients with lower ejection fraction will require vasopressors and inotropic support for hemodynamic stability in the post-cardiopulmonary bypass period. Nevertheless, there are few data comparing the outcomes among those patients and those with LVEFs over 35%. The left ventricular ejection fractions more than 35%. With that in mind, the researchers reviewed the records of 38 patients who underwent isolated CABG at the Medical College of Georgia between May 2020 and November 2021. Of these, 32 had LVEFs between 16 and 35%. Mean age 63.8 years. Median preoperative LVEF is 30%. While the remaining 6 had LVEFs of 15% or less. Mean age 64.8 years. Median preoperative LVEF 15%. As part of the study, the researchers calculated the vasoactive inotropic score, that is VIS, vasoactive inotropic score for each patient, which quantifies the degree of hemodynamic support received, with higher scores indicating higher levels of hemodynamic support. We utilize the VIS as it is a bit more of an objective way to look at relative drug administration and hemodynamic support. Small group numbers in a presentation at the 2022 annual meeting of the Society of Cardiovascular Anesthesiologists, Dr. Bailey reported that there was no statistical significant difference between the groups in terms of surgical variables such as cardiopulmonary bypass time and cross-clamping time, or in inotropic and vasopressor requirements. Comparison of patients with low and very low LVEFs, severely depressed LVEF, that is 15%, or depressed LVEF 16 to 35%. P-value of vasoactive inotropic score is 20.7514.130, 13 epinephrine mics per kg per minute, 0.04, or 0.42 millinone microgram per kilogram per minute, 0.31, 0.25 norepinephrine 1 microgram per kilogram per minute, 0.06, 0.29 vasopressin microgram per kilogram per minute, 0.007, 0.8 LVEF left ventricular ejection fraction. Drug doses expressed as median and interquartile range. Despite the findings, the investigators were quick to point out that the research was limited by its relatively small number of participants. So we would call it more of a pilot study and say our findings are more of a signal than anything else, Bailey said in an interview with Anesthesiology News. But in my mind, it still opens the door towards considering whether we can look at patients with extremely low ejection fractions in a different fashion than we had before. This may seem surprising to those that do a lot of mechanical support, but it would seem that you don't necessarily need mechanical support for every patient with a low ejection fraction. This much today in my lecture. I will come up with more materials in my next one. Hope everybody has enjoyed. Thank you.